Good evening. I'm Janice Grady, Executive Director for Development and Alumni Relations here at Columbia Nursing. I would like to welcome you to Social Justice and Global Health Equity in a Pandemic Era. As our program continues, feel free to utilize the chat feature to ask our speakers questions or comments, and if time allows, we will address these at the end of the program. Don't forget to check out the virtual poster session and pre-recorded programming on the Reunion website that you can enjoy on your own time. And now, I would like to introduce Jennifer Dohrn. Jennifer is the Assistant Dean for Global Initiatives. Welcome, Jennifer.
Thank you, Janice, and thank you to everyone in our audience, and a special thanks to the people who are participating in this panel. It's quite an honor for me to be amongst them, and some have been my students and some have been, all are my colleagues now, but many stories to share and about how we do global work looking for equity and justice in the world. When I graduated from Columbia University School of Nursing with a master's degree in midwifery and later my DNP, I sought out opportunities for global engagement that took me to the front lines of the HIV pandemic in South Africa in 2003, working side by side with midwives who literally moved mountains to provide care to pregnant women newly infected. This expanded to working with nursing communities in 10 sub-Saharan African countries to support capacity building for nursing education. I returned to the School of Nursing in 2014 to move forward the new energy and commitment to global health equity as essential for nursing education. At CUSON, we see the responsibility of nursing education is to prepare nurses to be on the front lines of providing safe and quality health care within the framework of social justice and health equity here in the US and across the globe. With the development of the Office of Global Initiatives in 2014, and now the Global Health Division in 2019, we have a dedicated program to providing an education that will enable all who graduate to enter the nursing profession and daily enact its ethical mandate to fight disparities, structural racism, and exclusion within healthcare systems around the world. We do this through global student clinical virtual experiences, learning primarily from nurses based in global South countries, through active participation in World Health Organization's network of collaborating centers, through global research on nurses on the front lines of pandemic response and forced migration. Those of us on this panel, all graduates of Columbia University, are here today to share our journeys onto the global stage to persist in seeking global health equity for all. So we're going to begin by having each of the panelists introduce themselves and speak about your nursing trajectory within the framework of social justice and health equity. So Meredith, I begin with you.
Thank you, Jennifer. It's really quite an opportunity to be here and talk to everyone. My name is Meredith Casella. I'm a nurse midwife, and I'm the Women's Health Coordinator at Hospital Universitaire de Mirebalais in the Central Plateau of Mirebalais of Haiti. And I'll tell you a little bit about how my global health path started. I was a Peace Corps volunteer in Niger and in Ghana, where I lived and worked for 5 years. And most of this time was on the eradication of guinea worm disease, which is a waterborne parasite. Over the 5 years that I was living and working in West Africa, I witnessed many births, and a few really stayed with me because of the mortality and the morbidity implications that they had on the lives of women. And this really put me on the path to becoming a nurse midwife. But more importantly, these experiences led me to become an advocate for the reduction of maternal mortality. I think we don't realize the impact that maternal mortality and morbidity has on families, on communities, and on nations until we ourselves are touched by a woman dying either in childbirth or in pregnancy. And then we come to better understand how the absence of a mother leaves not only her children, but everybody to suffer. So following my graduation from Columbia University in 2004, I worked on the Navajo Reservation for 2 years. And then I went to work in the Congo and in Chad with Médecins Sans Frontières, and followed by Haiti, where I've been for the past 12 years. The majority of this time, I've been with Partners in Health, Amis La Santé, and the mission of Partners in Health is to provide a preferential option for the poor in healthcare. This really speaks volumes regarding the services that we are committed to providing, and it's really in perfect alignment with my passion. Social medicine is the root of PIH's work in IT and consists of a community engaged and a whole patient holistic approach to obtain better health outcomes. We're also working towards establishing the University of Global Health Equity, IT, which is a satellite site of UGHE in Rwanda. And our vision is to serve as a national reference in the field of postgraduate
We'll wait one more moment to see if Meredith comes back with connectivity.
peripartum cardiomyopathy.
Well, we will come back to Meredith. One of the complicated things of being global, but we always persist and continue to move mountains. I want to just tell a very short story about reconnecting with Meredith, because I knew her when I was in the faculty in the midwifery program and director of the midwifery program at Columbia. She was a student, a midwifery student. So you fast forward 9 years and I'm in Haiti and travel to see the hospital that she's working at, not knowing that she's there, but because it's such a model for dealing with maternal mortality. And went in, and as I was walking into this beautiful place with paintings and sunlight and everything welcoming people as we want to do as nurses and midwives, I was going up a stairs and there was a woman coming down in scrubs and our eyes connected. One of those moments when you just connect with someone. And I thought, and then I was being taken upstairs to the medical director and I was doing protocol of introducing myself and he was welcoming me to the facility, and there's a knock on the door and he says, come in, and there's this woman and she says, Jennifer, it's you? This is Meredith. And a week later, I was back in New York at Columbia's Alumni Reunion week, just like this. And I said, talk about a small global world. Columbia nurses are indeed everywhere. So that was how Meredith and I reconnected, and I got to learn about her amazing work and her innovation and commitment to women. And here she is today. So thank you. Thank you, Meredith. Meredith, did you want to say anything else? I was just telling how we met.
Sorry about that connectivity issue. Is there another minute for me to continue, or?
Please do. I was just saying how we met in the hospital going down those stairs.
Oh, great. Yes, yes. So as I was saying, when we have a lot of the primary cause of maternal mortality here in Haiti is severe preeclampsia and eclampsia, and we frequently see peripartum cardiomyopathy as a sequela, which is mortal also if a woman gets pregnant again. And because the uptake of family planning here is very low, and family planning can decrease maternal mortality by up to 60% when all of a woman's needs are met, we came up with 3 different family planning strategies, and 2 of them are community-based, which have really had an impact on women's lives, really opening up accessibility, especially to women living in rural areas. We also came up with another strategy. The chief nursing officer and I conceptualized and started a comprehensive accompaniment approach to maternal, neonatal, and child health called J9. And J9 has 4 pillars, which is group antenatal care, group pediatric care, psychosocial support throughout pregnancy and throughout the baby's first year of life, and also home visits in pregnancy and postnatally. It's an integrated model of care that includes community support throughout pregnancy and the baby's first year of life. And we've really seen some wonderful results as a result of this program. including decreased cases of severe preeclampsia compared to the control cohort. So we've really, I feel like these experiences really speak to working with Partners in Health and working with ZL here in IUT and the impact and the results that we're having on maternal mortality and morbidity. Thank you.
Thank you, Meredith. I know there will be returning more to you to hear more of this and then talk about putting innovations into practice and also listening to communities, building programs based on what our communities' needs are so that they really are included. That's why we give healthcare. So thank you. Kyle, I'd like to have you speak next. Another student, actually.
Thank you for inviting me to this panel today. My name is Kyle Durrant. I was a graduate of the Master's Direct Entry into Nursing program at Columbia in 2018. Currently, I'm working on getting my Doctor of Nursing practice at Johns Hopkins School of Nursing. I'm a Johns Hopkins Center for American Indian Health, Sackler Institute Fellow. My background, I come from the Yakama Nation in Washington State. And one part of my work before I came to Columbia was working with Indigenous communities. I worked with the Seattle Indian Health Board, working on doing public health research initiatives. Then I moved to New York City, and I started my nursing career. While I was at Columbia, I participated in the Global Fellows Program and did my integration in Mekelle, Ethiopia. I worked on the adult medical surgical units while I was there, and that was an eye-opening experience to me, and I learned a lot about really working with community and community needs assessments and figuring out what we as institutions can do in partnership with the communities that we work with. When I graduated from Columbia, I began working with the Urban Indigenous Collective in New York City, and I'm currently working with other Indigenous health care providers, mental health care providers, and we're trying to develop a program now for Indigenous people in the tri-state area, Connecticut, New Jersey, New York, on creating different mental health services in partnership with the community that we serve. So we're and the other things that I've been involved in as of late, I'm also working. I'm also a registered nurse at Lenox Hill Hospital. I'm also interested in working on on correcting or addressing health disparities experienced by the LGBTQ plus community. And I've been working with Northwell Health on initiatives to address health disparities experienced by sexual and gender minorities throughout the Northwell Health System. Doing that work as part of the Expressions Business Employee Resource Group. But going forward, I definitely want to continue working with Indigenous communities and or working in global rural health as well to address health disparities experienced by different communities, and work in partnership with those communities to reach better health outcomes. So I am just starting my nursing journey. I've only been a nurse for a couple of years, but I'm hoping to continue my global health work, and I'm excited for what's in store for the future. So thank you again.
Thank you, Kyle. Impressive, and you're just starting this, but this has been part of your life's journey. So it's great to be working with you again and looking forward to more. Laura, I'd like you to speak and then introduce yourself. Laura Ridge.
Hi, thanks for having me. It's already been a real pleasure to hear about Meredith and Kyle's work. My name is Laura Ridge. I attended Columbia's entry to practice program, and I graduated with my RN in 2008 and my master's in 2010, adult nurse practitioner. I worked in New York City for some time afterwards at an addiction clinic and at Queens Hospital Center at what was at the time HHC, but is now H&H, New York City's public hospital system. I then went back for my PhD. I got my PhD from NYU, and I'm currently a postdoctoral fellow at the University of Michigan. While I was working in New York City, though, I reconnected with a professor at Columbia, Dr. Richard Garfield, who was at the School of Nursing and who had his doctorate in public health. And he and I co-founded a small nonprofit called Nursing for All, which supports nurse-led public health initiatives in Liberia. And it's really exciting to hear about Kyle and Meredith's work because it feels like so many of the same values are echoing through each of our talks. The nurses who develop these interventions develop them for the communities that they live in. They use evidence-based practices to facilitate service delivery in the community for free. We have a variety of family planning programs. We have a few hypertension and diabetes management programs. We have a dental health program, which is very exciting and which requires me to learn a lot about dental health. And it's really wonderful to see the nurses take the reins and run with it. They're constantly returning to NFA saying, we have this idea, this improvement, this expansion. We've had a wonderful time getting to know them over the years and seeing them really strengthen their communities from the inside out. This has obviously been a challenging year because of COVID. That said, COVID outcomes in Liberia are far better than they are in most countries. However, the nurses, I think, are part of the reason that that's true because they designed and implemented COVID prevention initiatives with their usual agility and acumen. They really know what their communities need and how to get it to them, and it's really remarkable. So it's exciting to be on a panel with other people who place community-based nurse leadership at the center of their practice and their lives. So thank you very much.
Thank you. Thank you, Laura, so much. And I think one of the essences of global nursing that we learn constantly, those of us who have started our practice here in the United States, is the true value of public health and community-based health, and that nursing is that link oftentimes between the community and policy, and the protector and the advocate for the community we serve. And there are teachers, and that's the right order always to have it, right? As they start with the wisdom, and that's what we carry forward. Patricia, a colleague from Rwanda, work in Rwanda. Can you speak to us a little?
Yes, thank you very much. My name is Patricia Moreland. I'm an assistant professor from Emory University, Lillian Carter Center. That's a global health department. So my global work has been in Rwanda, East Africa, through the Human Resources for Health program, HRH was a 7-year capacity building initiative, and it was a collaboration between the government of Rwanda and 26 US-based academic institutions. And the program ran from 2012 to 2019. I lived and worked in Rwanda for 5 years, from 2012 to 2017. So the goal of HRH, it was the first time any type of initiative like this had ever been done, but it was pretty much educational, and the goal was to increase the quantity of healthcare providers in Rwanda and the quality of their education. In 2012, when the program began, 80% of the nurses in Rwanda were high school educated. And there were only 3 PhD prepared nurses in the entire country. So it was one of many of our initiatives was to raise the education of those who were at the high school level up to the diploma level. So I joined HRH in 2012 as lead faculty for Duke University. And August 1st, which I will always remember, in August 1st, 2012, 120 physicians and nurses were deployed to Rwanda. And we covered all 5 provinces of Rwanda. And our goal again was to educate with our Rwandan colleagues. When you arrived in country, you were assigned a Rwandan twin, and you did everything with your twin. You taught with your twin, you did meetings with your twin. We did nothing without our twin, no meetings, anything, because honestly, you don't know how much you don't know until you get into the country, because we don't manage malaria here in Rwanda. We don't, I mean, in the US, we don't manage severe malnutrition. Those are all things that I learned. So that was one of the initiatives and sustainability factors of this program. And this actually was initially initiated by the former president, Bill Clinton. He was very much involved with this. And I know we saw Paul Farmer a lot from PIH, because Paul Farmer is totally involved in both Haiti and Rwanda. So we often met with Paul Farmer. He's amazing person from PIH. So I was in the rural area of Rwanda for 3 years, and then in 2015, I was transferred from the rural area to the University of Rwanda, which is in the capital city of Kigali. So I went to Kigali, and we were all brought in from the rural areas at that time to build the first Master's in Science nursing program in Rwanda. There was no bridge between the baccalaureate program and the PhD. There was no master's program in the country, so the only way that nurses could get a master's degree was to get a scholarship in another country, which is very difficult because they have to leave their families for 2 years. Mostly they went to South Africa to get that, but only few. So that was the initiative that we had, to come in, write the curriculum, build the curriculum, clinical, everything had to be done. And again, we do it with our colleagues, our Rwandan colleagues. And it had to be internationally approved, the curriculum. And then we began to teach in 2015. And in 2017, I'm proud to say that we graduated 111 MSN, master's prepared nurses from 8 different specialties. And all these specialties were chosen by the Minister of Health of Rwanda. And these students have gone on to now become the leaders in their education. And they are now also, many of them are getting their PhD, because that was not there. So actually making national history in Rwanda in 2017. I was so proud of our students. And, you know, they have many, many challenges because they're working full time, they have families, they're traveling 5 hours on the bus to get to, you know, come to the University of Rwanda to get an education. And it was just an honor to be there in Rwanda. And I still continue to collaborate with them. We've done quite a bit of research there, and so yeah, that's Rwanda.
Thank you, Patricia. I mean, I'm looking at all the threads that connect us as we talk about the work that we've all dedicated our lives to, and so many commonalities amongst all of us. And one interesting addition, which connects Meredith and you and Laura, is that now, Liberia, is that now the head of Partners in Health, the chief executive officer, is Sheila Davis, a longtime global nursing leader. And, you know, we are breaking through, and we're in policy and leadership, as you are all exhibiting and showing with us. So it's a very important thing to acknowledge, right, when we're and support each other in doing this. So Julie, thank you for being here. I want you to just tell us a little bit about your journey around global health equity.
Hi, everyone. Thank you so much for having me. I'm Julie Yoshimachi. First of all, I apologize, especially to my fellow panelists, for being a little bit late. I forget, don't take a car service when you're in a rush in New York City. So I apologize. Thank you so much for having me. I'm honored to be a part of this group. Again, I'm Julie Yoshimachi. I graduated from the Master's Direct Entry program in 2017, and then the DMP Family program in 2020. Currently, I'm working at a community health center based with a focus in Asian Americans in New York City, in close to Chinatown here in New York City, which I'll talk a little bit more about. Similar to Kyle, I think part of my role here is also to talk about my time as a student. I had the most amazing opportunity to go to Malawi during my MD, as well as my DMP. So I had the opportunity to go twice. And so as a nursing student and then a nurse practitioner student, and so into the same hospital. So, you know, just like Kyle said, it was definitely an eye-opening experience. And part of what was really, you know, there was so much to learn and so much to take in, and definitely kind of connects to my role right now and what I want to do here, but also in the future. And, you know, the really nice thing was, you know, the second time I went back to Malawi, you know, the staff and the people who I worked with actually like remembered my name, and remembered when I was there and asked about my classmates that I was there with. And it was just, that was amazing as it was. There's always like, you know, people coming and going at that hospital from different countries. And so, you know, I learned so much, not just about medicine, but also sort of the compassionate aspect of nursing and medical care in an environment that, you know, may lack resources that we fortunately have here in the United States. And also not just from the staff and, you know, medical staff, but also from the patients themselves, patients and families. I learned so much. You know, in the United States, we don't really have sort of a culture of families helping care in the hospital rooms. And so, you know, integrating family more and more into practice was also something that I really, you kind of knew in your head, being in the US, but it was really integrated into practice, I felt, and when I was there in Malawi, and, you know, learned so much just from the patients and families. And I always kind of think about this and kind of try to remind myself every day, but, you know, they say thank you for everything, which, you know, was kind of an amazing thing. So simple and something that, you know, you kind of take for granted, but, you know, patients and families telling you thank you, but also you thanking, you know, everybody that you work with and patients and families. And so I learned so much, not just about sort of medical care, but also sort of the root of what's important in medical care, starting with, you know, what's important in connecting human to human. I had a lot of opportunities to connect really well with a lot of the nurses there, and we spoke a lot about what they also wanted and what they felt like they wanted to do in their careers. And I met a particular nurse who really wants to empower her fellow colleagues more. And so I'm really interested, actually, especially in like Laura's work. I've been following her work for a little bit. So, you know, we've been talking a lot about how we can collaborate more in the future. And so she's also getting right now her master's in China. And so, you know, she's going to go back and really integrate different things into her work environment. So we're hoping somewhere down the line that we get to collaborate more. And, you know, I just partially also that I love Malawi so much. I hope I get to go back soon. But one thing that I did really learn from Malawi that connects to my current work is the importance of preventative care, which I didn't think about so much. I was more in like emergency care before urgent care. But in Malawi, there wasn't a really great base in terms of preventative care. So patients would only be seen, for example, for diabetes, like once it was almost, too late, like they had to get amputations and their sugar was too high and they hadn't been seen in a while. Partially, of course, access and many different things. So now I'm a primary care nurse practitioner at a community health center, like I said, at a community health center in China, close to Chinatown, and with a focus on Asian Americans. And so I think, I have a lot of appreciation for being able to provide preventative care now, and kind of, I feel like, I didn't realize how important it would be, for sure, until, I went to Malawi. Another part that definitely I think relates to this topic is sort of everything that's going around with social, with racism and social justice, for sure, in our society. And, considering the type of community health center we're at, we're talking a lot about within staff, but also with our patients about, anti-Asian hate and sort of understanding what's going on. Actually, a Columbia nursing graduate is also leading one of our sort of staff initiatives, so that we can talk more about this and understand, but also make sure we're there for patients and sort of understanding where their fear and sort of anxiety is at in terms of that. So I'm definitely also just like new into my career, but I have, I definitely, as Jennifer always says, global is not outside of the US, it includes the US. And so I really hope that, starting from here, I can do more, hopefully I can do more work sort of in the future as well.
Thank you, Julie. I'm having a lot of thoughts of going along your journey with you. Thank you for sharing this. I want to narrow in and focus on this current time with each of you. And it's a time, one of war and forced migration. And I raise that because in hearing Kyle, you speak about Mekelle in the Tigrayan region in Ethiopia, our colleagues there are under war conditions and genocide and mass murder, and we're sending our best to them and trying to stay in touch when we can get word, which is very rarely, and very engaged with this. And also the pandemic, the COVID-19 pandemic. I woke up this morning to sorry, I'm in someone else's house and their phone is ringing. I woke up this morning to a WhatsApp from a dear colleague, Sister Lurdu in Bangalore, India, who I've been writing almost daily. And she just woke me up this morning and said, Jennifer, pray for India, pray for Bangalore, pray for all of us. Arundhati Roy, the Indian poet and activist, said, the pandemic is a portal. It unmasks the fractures within societies, revealing the inequities and injustice, and also challenging us to build differently going forward. We can choose to walk through lightly with little luggage, ready to imagine another world and ready to fight for it. HIV, Ebola, Zika, COVID-19 are all revealing these great disparities and fractures within our societies and across the world, and how we respond as nurses. So I would like each of you to tell us a little more about your work and the impact of the pandemic and on the communities you serve in your response. Meredith, could you start?
Sure, thank you. Thank you for that quote. That was really beautiful. Yeah, the pandemic has touched everyone here as well. On the 19th of March, 2020, the president of Haiti, Jovenel Moïse, confirmed that there were two individuals who had tested positive here. And those two patients were sent to HUM, the hospital where I'm working, for treatment. So HUM was the first hospital in Haiti to treat COVID-19 patients in our Unité de Maladies Infectieuses, our infectious disease unit. So in the beginning of the pandemic, both staff and infected patients were stigmatized, and many staff received threats there was just a lot of fear about the unknown about this virus. So in order to abide by the national regulations, staff started to spend 1 to 2 weeks at a time at the hospital to reduce the flow of patients and to reduce the patients and the staff also, and to limit the risk of transmission. So while providing care to COVID-19 patients, it remains important to continue to provide essential quality services to our patients at HUM and at all of the 11 other sites. So in terms of modifications to our prenatal and women's health services, we continue to make family planning accessibility a priority. In terms of the prenatal groups, we limited our groups to 5 rather than 10 women in the groups and spaced out the visits to every other month. We provided telehealth. We called women on a monthly basis, but also more frequently to our women who were at higher risk. We modified our home visits. We weren't doing home visits to the pregnant patients as regularly and our postpartum patients as regularly, but we prioritized rather our gender-based violence victims so that we were able to remain in contact with them, because the psychologists a lot of times hadn't heard from some of those patients. So we really wanted to reinforce that, the couples counseling, especially in the home. But since October of 2020, we are now back to our normal group prenatal, group pediatric visits, our normal home visits, and we're providing family planning, prenatal, pediatric visits in the homes, and also referring when necessary to the hospital.
Thank you. Kyle, any reflections from Meredith's words or my question?
Thank you, Meredith, for sharing. And thank you, Dr. Dohrn. As you mentioned, in Mekelle, Ethiopia, in the Tigray region, it's been a tumultuous time, especially between the ongoing conflict between Eritrea and Ethiopia. Unfortunately, I've also been keeping in contact with the nurse colleagues that I've met over there. One of my nurse colleagues, I was working on a research project, and I was going to help at their paper, but I haven't. It's been hard getting a hold of colleagues there as of late, and I'm always have them in my thoughts and prayers, and I try to do what I can from afar. But this has been, I think, a tumultuous time it has been a tumultuous time for everyone across the globe. And in my current work in New York City, it's also been tumultuous. Right now I'm working at Lenox Hill Hospital. My job is as a medical surgical telemetry float pool nurse. And there's been one thing that I recommend. Netflix did a series on Lenox Hill, and the last episode of the series, it's called the Pandemic episode, and it really showcases what was happening at my hospital during the height of the pandemic in March and April, May. Things have gotten a lot better, at least at where I'm at, but it's been quite a journey. I remember we had to open up office spaces just to turn them into rooms, and we opened up literal rooms from closets and made them into patient rooms. We had lost oxygen at one point in our hospital, and it really reminded me of how, even though Lenox Hill's in one of the most influential zip codes in the nation on the Upper East Side, how the pandemic really had we caused such a big resource limitations that even in the Upper East Side at the height of the pandemic, we didn't even have the resources we needed to all the time to provide the care that we needed. Not enough ventilators, all these things. Now that's not so much an issue, but the COVID-19 pandemic has definitely, I think, impacted everyone's work in the healthcare industry. And fortunately, New York City, I think, we've been able to implement different public health initiatives, and our COVID census has gone down, at least across our hospitals at Northwell Health. But I also look at my relatives back on the reservation and on the Yakima res, and I have many family members who ended up passing away because of the lack of resources that was available through the Indian, through the tribal health system, the Indian Health Service clinics. Fortunately, we've been able to address, the Indian Health Service has been able to address a lot of those issues. And now a lot of tribes have actually been on the forefront of vaccination efforts across the nation. And has actually, a lot of tribal nations are seeing greater vaccination uptake than in a lot of areas of the country, which has been amazing. And the work of the healthcare providers across tribal healthcare facilities across the United States has been nothing short of incredible. So, but thank you. Yeah, thanks for listening.
Thank you, Kyle. Patricia, reflections about the pandemic in global work?
Right. So our research in Rwanda has definitely slowed down. Weren't able to go in during the pandemic just because of, how rapidly it was spreading. Rwanda did some amazing things to protect their country, though. So all of the hospital wards are open rooms, probably like what you saw in Malawi and Haiti, where it's just one room and 15 beds in that room. So what Rwanda did is they went in throughout the country and took over hotels, because hotels have doors, and they set up ICU and hotel and sent doctors and nurses to these hotels throughout the country to help, decrease the spread of the pandemic. They also, everyone that landed in the country went into quarantine for 2 weeks. It wasn't a request. It was a, demand that they could not come into the country without being put in quarantine for 2 weeks. And they took them directly from the airport to a hotel. They didn't, the government paid for the hotel, the food and everything, but they had to be in quarantine. Rwanda is also using robots. I don't know if you've seen these from the World Health Organization. They have robots because one of the biggest fears, because there's so few doctors and nurses in the country, that if they become sick, there will be nobody there to care for the patients. So these robots can actually take your temperature. The doctor or nurse can talk through the robot to the patient. They're actually very amazing. If you get a chance, look up Rwanda and robots on the internet. They've done just incredible things. Rwanda is a very hilly country, so they're actually using drones. So drones, they came into the country about 2015, and they have the ability to land within the space of a driveway. And so if you need blood, one of the biggest problems is getting blood If you're very remote in the rural area and you need blood can now go by a drone and it can get there within 15 minutes. And because Rwanda, very mountainous, very hilly, very difficult to travel. And so they're using drones to deliver medication and PPE. So they are, I don't know, they're just so creative, and they are getting the vaccine now. There's, not nearly enough, only enough right now to do the healthcare workers. But I think that's a huge social justice issue right now, is the fact that someone needs to release that formula so these countries can start making their own vaccine. Because you look at India, as Jennifer said, that's just a prime example. We not only need to release a vaccine, the formula for that, but we also need to support them so they can make it on their own. So that, to me, is like one of the biggest social justice globally that we're looking at today.
Rwanda, the land of 1,000 hills.
Mm-hmm.
I remember the first time I landed there. And when one thing about Rwanda, Patricia, that you know well, the first time I landed there, I was immediately taken to the Genocide Museum. It's a part of your entry into the country to respect where they've come from and to honor the dead and look at before you can go forward. So place dear to my heart. Julie, I know we've talked, I did an interview with you on nurses responding to the pandemic in New York City. Some thoughts of yours?
Yeah, so as a primary care provider, I'm not in a hospital setting, but definitely, I think, well, I was actually fairly new nurse practitioner. I started in March at my job, so it was like right before the lockdown. So since I didn't really have, my own patient panel yet, I ended up sort of becoming like the main COVID tester and seeing all the patients who came in for COVID. At first, we definitely moved right into telemedicine and only saw patients as needed. But I think one of the biggest things I think a lot of, maybe primary care places are seeing is that, patients, because they haven't been coming out of their homes or seeing their, medical providers, we're becoming more sick also over time due to non-COVID related medical issues. And so a lot of it was also how to now better manage that, but over the phone or video. And but also even with COVID, I think, if patients had COVID, a lot of times we would just monitor them daily. So we would call them daily and make sure they were okay, which worked, fortunately or unfortunately, really well. This past couple months, there was a variant in New York City, and a lot of individuals, like middle-aged individuals, would get very sick around 7 days, even though they were doing really well. And so, but following with them daily allowed us to, be able to send them to the emergency room right away if necessary, considering patients were so afraid to leave their houses or especially go to the hospital. So, I think in that sense, like Kyle was saying, things are definitely looking quote unquote normal. Patients are coming in for their more follow-ups and annual visits again, but even annual visits, like young individuals who just wanted to get tested but never had any symptoms or exposure would test positive too. So, a lot of this was like better education, and also just making sure to answer questions for, there's so much information going around, so much right or wrong information, but making sure patients and families understood what was correct. We've become a really big vaccine site in the community. So we've given, I think, close to now 40,000 vaccines in the community. And so we've been doing really well at that, which, our staff have been working so hard. So we're hoping that to keep those efforts up and kind of keep working with the city on that. But kind of like Kai was saying, I've been in touch with some of the people in Malawi, and they were the kind of the first people I thought about during the pandemic, because I was so worried they already didn't have enough resources to begin with. It sounds like they really had to cut back on quote elective surgeries, which pretty much meant anything that wasn't emergency. But it sounds like they were doing okay for a little while, but definitely kind of keeping an eye out and being in touch with them. So
thank you. And everyone on this panel is extremely modest, But I do want to say, when I first did an interview, and I'm on a project that Laura helped me find the connections to do oral histories with nurses and midwives in Sierra Leone and Liberia. All of these networks are incredibly important to how we build global. And and then I started doing interviews after a website, which we just started at Columbia University, on the oral histories of what nurses and midwives, what they learned about pandemic response, not knowing we would walk into COVID-19 right when we were preparing and analyzing their stories, and what they thought of roles in leadership and guidelines and what could be done differently by putting nurses in a higher level of authority, and is also the connection to the community, to really represent the community. And so I then expanded that project to interview nurses on the front lines in COVID-19 in New York City last April, May, June, and it still is ongoing. And when I first asked Julie and she agreed to let me interview her, she had been on the job 1 week when the clinic, when there was a closing out of New York City. A young Asian American woman, she's riding the subways every day to work back, exposing herself to infection and also harassment. Braved that, and then realized most of the staff at her community health center had children and families, and thought they should work from home. I'll be the person to volunteer to go into the clinic every day. So this is the ethos that I think is something that is essential for the work we do around equity, and is encouraged at Columbia University. And not just encouraged, it's part of how we teach. It's part of having clinical sites in many countries. It's part of addressing structural racism and pushing us all as a school to be better and be appropriate and be on the front lines of really where we go forward. So with the time left, I would like to go back to each of you and have you reflect a little bit on your nursing education and your own advice, where you are now in the amazing work you're each doing around global health equity. What would you best advise as ways to prepare future nurses for professional engagement in issues of social, racial justice, and health equity? Big question. You've all been doing this. So advice back to Columbia University. Meredith?
Thank you so much, Jennifer. You mentioned reduction of inequities, and I feel like we can really advocate for the reduction of these inequities, looking at health systems themselves that create inequities. We can build curriculum around creating a deeper understanding of the inequities within hierarchies. I feel like we could, within the education system, we could look at the historical legacies of colonialism that perpetuate structural racism. And then aside from education and health systems, the future nurses could really be open to learning in low and middle income countries in the settings, empowering and engaging local community members and to work to have their voices heard. I feel like it's really important to create sustainability, capacity building, working on a team. International work is not about individuals, it's really about working together, teaching, accompanying. That lesson has repeated itself many times for me. So just in order to foster this sustainable change, I think it's really important to build the local capacity, local community capacity, but also nursing capacity. So thank you for that question.
Thank you for that answer. Kyle?
Yes, thank you, Meredith. I think a lot of what Meredith was saying, I also agree with, that we need to have a more of a local context and invite the community as well to look to help with that capacity building, but we also need to look at implicit bias training. I think that's one thing that I think would help us as nurses in our training before we start practicing. I know that's a big initiative currently with nurses that healthcare institutions are implementing implicit bias training in nurses currently practicing, but I think having that before practice would also be beneficial to help address our own biases that contribute to health disparities. So that's, I think, a major thing that we could address in our current nursing education curriculum.
Thank you, Laura.
I completely agree with what Meredith and Kyle have said. I think that we can no longer assume that we're not part of the problem. We can't start in that place. We have to think critically about our role in what we're trying to address. Even as nurses, I think we have, especially as nurses, I think we have to think carefully about how our individual actions and the actions of the systems that we support contribute to health disparities. I do think nursing training is very good training, though, for doing the most important thing, which is listening to the communities that are affected. I think that we're taught to think holistically about people and to acknowledge them as complex and individual. And I think that that's incredibly important. That's an incredibly important place to come from when you're thinking about how you can be a good ally or be a good leader, depending on your relationship to the cause. And so I think that we have to sort of be proud of our background as nurses, but also recognize that it doesn't mean that we always have the right idea or that we're always moving in the right direction. We have to listen first.
Wise words indeed. Patricia?
Yes, I agree with what everyone has said. At Emory University, we're doing implicit bias training for all faculty and all students. It's incorporated within their courses. The thing I always think about as faculty, our responsibility is we often tell students, this is a safe space, you can talk about anything, but I think we have to act in a way that really supports that statement so that they do feel they can speak. Our Dean, Dean McCauley, whenever something happens in the community, such as the George Floyd killing, we do not carry on classes as normal. We stop, we talk, we have the students talk. It's not business as usual at all. We have to let the students speak. So, but we have, we have a lot of work left to do.
Yes, nothing proceeds, right? It's normal. When this is crisis and great injustice, everything does need to stop. Julie, any last thoughts?
Yeah, I think definitely agreeing with everyone as well. And I think, I was as a student leader during my time at Columbia, I think one of the biggest things I tell students also is, Columbia has so many amazing resources and so many amazing opportunities. And so really taking advantage of those opportunities, but also working together, to see how, students can have access to those opportunities. Many schools don't have opportunities like global integration or global clinical, for example, or these opportunities to really talk about what it means to be global and to have social justice. And so really, allowing students, but also alumni, for everyone to come together, staff, faculty, and really be able to talk about these things, I think is really important.
Thank you. And I think if you stay in, people get engaged in the rest of this week, there's going to be great discussion of what at the School of Nursing we have been doing to go deep structurally into racism and exclusion, and what is the transformation that needs to happen for faculty, with students, with the entire school, in concrete steps to take us into a new future. And one last word I want to say is that When we built the student clinical experiences program, which it's gone from 60 to 70, 80 people attending. This year we're doing it virtually. So students are starting tomorrow and had to apply and get selected to a site. And sites took this very seriously in the middle of the pandemic, that they were going to have a learning experience and a project for students to produce that they needed at that site by the end of the 5 weeks, with the hope that when things change, we will be able to send students, but you don't just put global on hold. The global world is in crisis. Our healthcare is in crisis everywhere. So we're there with each other. And the program from the beginning was a reciprocal program, with leadership being in country. And I think that's the only way that we build global, right? We are there to learn. We bring our humble ideas and knowledge that we have, and then we listen and we learn and we watch. We watch interactions with communities. We watch how nurses respond to unimaginable situations and continue to go forward day after day with many, many small victories and sometimes large victories. And that changes the whole perspective, deepens it into really saying, when I graduate, yes, I am a Columbia nurse, and my life wherever I am is going to contain, my work will contain looking at equity issues and healthcare for all, and repairing the breach of great disparity between global North and global South. So I want to thank you all for being here today. I wish we could keep going on. There's so many things to ask each of you, but it was really a wonderful gathering for me and for the school. And I hope for our alumni. Our Alumni Association has been enormously supportive in yearly raising funds for our global students to be able to participate at sites. We would not exist without the Alumni Association support for this program and its global fellows contributions. So big applause to all of the alumni out there for taking this in and making this program come to life and bear great fruit, as you can see from the many students who are on this panel and the trajectories they've gone on to really part of changing the world and improving healthcare for all. Thank you so much.